this is the framework for how to grow and become better and be successful in whatever you want to do. What is the goal? You know, how does this goal unlock your own personal growth and potential? Nothing happens in life if it's not intentional. You have to commit. You have to say, this is it. I'm going to do it, and how are you going to do it? And don't expect that it's downhill. Everything worth doing in this world, it's always uphill. But those things can only make you to become better and better, not for you to make a U-turn. Stand firm on your commitment and share with others. I think we closed on something like this on Tuesday to say, as you share, some people will be happy with your growth, some people won't be happy, and hence we continue to outgrow people, but life introduces us to people who help us to become better and better. So one way to grow yourself, especially if you are a medical doctor, is to do a postgraduate diploma exam with the College of Medicine of South Africa. We have the HIV medicine, internal medicine, obstetrics, child health. We are continuing to grow what we are able to offer. These programs are open for registration. We are going to be hosting a series of information sessions for all this, and then close with a big one where we bring people who have been through the programs and they tell you, I mean, people have passed. It's so good to get that feedback, and we're going to run a survey so that we can give you proper feedback. Just to say that the diploma in anesthesiology is open. You can register your interest in it, and then the actual registration will open early in the week. Also, ophthalmology, we are ready. I know people have been saying DPEC, emergency, it's coming, it's coming, it's coming. I thought we got it right, but these programs always require the right partnership. Dr. Ryan will tell you the effort they require, that particular 3 months coaching. So if we don't want to start and stop in the middle of the program, but God is always with us. He will bring the right people into our lives. And yeah, I don't want to talk much about this. Oh yeah, Saturday it's me and the nurses, and we are going to be mastering HIV medicine. So if you are here, you are a nurse, you want to get quick updates on the HIV management in your space, we call it a NIMART update. Don't miss it for nothing. And last year we had this palpation fine needle aspiration boot camp. It was here in Joburg. This year it's heading to Durban, and I'm gonna pass by. I'm gonna pass by Brother Ryan's home. So, brother, please prepare the coffee there.
The biryani, brother.
Yeah, as I pass by Peter Marisburg there, at least I must see you. We must connect. This thing of connecting virtually, it can't be. So that is 25 October. All right, colleagues, this is it. Today we are building up on the Think Like a Physician webinar series, and it's such a great honor to have Dr. Ryan Swepesat back on board. We are discussing the platelets. And like I said, I felt very exhausted today, but I know in the next hour, I'm going to be so energized with all the dirty jokes that we are going to have. Brother Ryan, can I hand over to you?
Yeah, well, thank you, my dear brother. Oh, it's been a
Awesome.
long time, Lesego. I think you've gotten taller since the
Hey,
last time I saw you, eh?
hey, these weeks are too long.
Hey, thank you, brother.
Uh,
Very good evening. Good evening, everybody. Sanbonani, Huyenant, Buenas noches, Dumelang. A very good
Dumela.
evening. Dumela, yeah. Very good evening, everybody, and thanks for joining us. We're talking about platelets tonight. It's our 31st, can you believe it? Our 31st installment in Think Like a Physician. I hope you and your family are well. Yeah, and of course, it's always good to start with an attitude of gratitude, to thank, first of all, my Lord and Savior Jesus Christ for the opportunity to speak. The scripture tells us, give thanks not sometimes, but all times. This is God's will for you. The psalmist also encourages us by saying, give thanks to the Lord. Indeed, and we also give thanks to God for people like Brother Moela and the CCP who sacrifice tirelessly, day in, day out, week in, week out, webinar in, webinar out, masterclass in, masterclass out. Thank you, brother. Thank you for your team and the sacrifice and dedication you put into empowering and motivating us. God richly bless you. And of
Thank you.
course, a big thank you Thank you, brother. And a big thank you to everybody that's on board. We appreciate each and every one of you. So, quick preamble. Okay. Quick preamble, guys. To those of you who are not familiar with the Think Like a Physician webinar series, here are our objectives. At the end of each lecture, we hope to list the common and dangerous diagnoses that can potentially cause each symptom. Today, we're talking about platelet disorders, okay? Now, you should be able to develop a basic diagnostic plan for your patient with a symptom, which is balanced between being rapid, low risk, and cost effective. Now, we've always got to think about cost in our setting. So we're going to try and be as effective at as low a cost as possible. So each lecture is going to follow the following format. We're going to first introduce a couple of terms and definitions, then break into a diagnostic framework. What is a diagnostic framework? It is simply a list of diagnoses which can explain the presence of a specific symptom, physical exam finding, or diagnostic test abnormality. And today we're talking about low platelets, organized into discrete categories. Now, in times past, we used maybe systems to clarify our approach. For instance, when we spoke about chest pain, and then sometimes you want to talk about pathophysiological mechanism, which seems to be a better branch point, as when we discussed lower extremity edema, maybe anatomical subdivisions, as when we spoke about abdominal pain. Okay. And then from there, we're going to go through a diagnostic algorithm. And then we're going to talk about some clinical pearls regarding diagnostic strategy. And then I'm going to give you a doggy bag of takeaway points. Okay. So we've covered 30 topics. This is our 31st. So I'm glad to have you on board. And of course, I got my daddy jokes in between. Speaking of which, here's the first one. I just seen a burglar kicking his own door down. And I asked him, hey, what are you doing, man? And he says, no, I'm working from home. Yeah. Okay, guys, here's our clinical case for the day. So, I always like to give you guys a clinical case to kind of give you some context into the scenario that we're talking about or into the topic that we're talking about. Previously healthy 39-year-old man presents to the emergency department with fatigue and malaise over the last 5 days. Now, he also complains of a skin rash on his lower extremities and intermittent fever. Okay, that's interesting. Fever and rash is always a nice combination. He began bleeding from his gums on the day of presentation. Oh, it's getting more and more interesting. When his wife noticed confusion, she brought him to the ED. So we got bleeding, we got confusion, we got fever, and we got rash. Okay. Temperature is 37.7, not bad. There's scleral icterus and subconjunctival pallor. They are innumerable 0.5 to 12 millimeter non-blanching erythematous macules on the lower extremities. Splenomegaly is not appreciated. All right. Peripheral white cell count is 8,000 per microliter, which is normal. Hemoglobin 6.2, which is low. Platelets are 6,000 per microliter. So platelet count is 6. The corrected tick count is 18%, and the immature platelet fraction is 22%. Serum creatinine is 210, so he has some kind of kidney injury going on, together with a total bilirubin of 52, with an indirect component of 37. So he has a unconjugated hyperbilirubinemia together with acute kidney injury. Peripheral smear is shown here. Okay, feast your eyes on this beautiful peripheral smear. And the question goes on to ask, what is the most likely cause of thrombocytopenia in this patient? Now we've got a couple of abbreviations here. Don't worry, if you're not familiar with these, hopefully by the end of today's session, you will be comfortable with these. So ITP is immune thrombocytopenic purpura, TTP is thrombotic thrombocytopenic purpura, DIC is disseminated intravascular coagulation, and is heparin-induced thrombocytosis and thrombocytopenia, or thrombosis and thrombocytopenia. And OGK is only God knows. Let's refer to hematology. Okay, so let's go, guys. So, a good question to ask is, how is platelet production normally regulated? Now, for those of us who are unfamiliar, platelets are the cells that help our blood to clot. Now, platelets are generated from these big cells called megakaryocytes, and these are derived from megakaryoplasts, okay, which are produced in the bone marrow from myeloid progenitor cells. Now, the principal regulator of platelet production is this beautiful hormone called thrombopoietin, which is majorly produced in the liver and a little bit from the kidneys. Now, under normal circumstances, decreases in platelet and megakaryocyte mass stimulate the production of this beautiful hormone thrombopoietin. Now, how long does your platelet survive in circulation? Only about 9 days, guys. And thereafter, it's removed by the reticuloendothelial system. Now, uh, why did God give us platelets? Well, platelets are essential to form what we call a primary hemostatic plug. Yeah, I know we're going back to this hemostasis thing from first year medicine, okay? But we're not going to get into too much of detail. So hemostasis basically has two phases. There's primary hemostasis and then there's secondary hemostasis. So imagine now if you were to cut yourself. The immediate response of the body requires three elements. You require vasospasm, which is dependent on endothelial function. You require platelet secretion and aggregation, and you require von Willebrand factor, right? VWF. Now, von Willebrand factor is like the sticky paper which connects your platelets to the underlying endothelium. So when these three come together, that's your platelets, your von Willebrand factor, and your endothelium, they form a primary hemostatic plug, or as shown here. The problem is that this primary plug is not very strong. It's not very robust. It needs to be strengthened and reestablished. And that is why we have coagulation factors. These factors ultimately are a system of enzymes which cleave the production of each other and produce the more active form of the downstream enzyme. And ultimately, you produce something called fibrin. Now, fibrin kind of solidifies your primary hemostatic plug to make it more solid and more resistant from breakdown. Okay, and that's when we speak about everybody's favorite coagulation pathway. We're not going to get into too much detail, guys. Just know that there's an intrinsic pathway and extrinsic pathway, and there's a common pathway. So the extrinsic pathway starts with tissue factor, and the intrinsic pathway starts with factor 12, which activates factor 11, which activates factor 9, which activates factor 8 in the presence of calcium, and factor 5 in the presence of phospholipid, converts factor 2 into activated factor 2, which is prothrombin to thrombin, and that leads to fibrinogen becoming fibrin, and that is what we want. We want fibrin to come and solidify our primary platelet plug to make it nice and strong and robust and indestructible, right? Okay, so that leads us to what really is the primary function of platelets, okay? So we said that they're important for the integrity of the vascular system. And I think we've been through the process of primary and secondary hemostasis, okay? So just to reiterate, when you have trauma to your vessel, vasoconstriction happens first. Then we have the secretion of mediators, which causes platelets to become aggregated and activated, right? And they then bind to a Willebrand factor, which sticks them onto the endothelium. We have the primary platelet plug, and then we have the activation by a tissue factor of coagulation cascade. Ultimately, we have fibrinogen becoming fibrin. We have a beautiful solid blood clot. Remember that in the body, you've got to have homeostasis. So once the blood clot has done its duty, then we have the process of fibrinolysis, and that's when we talk about plasmin, but we're not going to focus on that tonight, okay? Right, so what are the clinical manifestations of platelet disorders? Well, these include easy bruising, all right, excessive bleeding, and you may have petechial or purpuric rash. Now, bleeding in the context of platelet problems tends to occur superficially in the skin and in the mucosa, for instance, from the gums or from the nasal mucosa. Okay, now in strong contrast to coagulation disorders, where bleeding tends to happen deeper down. Okay, you may have retroperitoneal hemorrhages, you have ecchymoses, you have bleeding to the joints, so you have hemarthrosis. Okay, so that's one important factor clinically to differentiate what the problem is. If it's a platelet problem, it's superficial bleeding. If it's a factor problem, it is deep-seated bleeding. Okay, now some conditions may affect both platelets and the coagulation cascade. And the classic example is von Willebrand disease, which results in a mixed clinical picture. We'll talk about that a bit later. So this is a beautiful picture of what petechiae look like. Very small, pinhead-sized lesions, right? And this is a picture taken from Callie and O'Connor. Okay, so what are really petechiae and purpura? Well, these are the result of extravasation of blood from the vasculature into the skin or the mucosa, usually occurring in the dependent regions of the body, but not always. Now, petechiae, we know, are pinpoint hemorrhages, classically below 2 millimeters in size. whereas purpura are a bit larger and they range from about 2 millimeters to about 1 centimeter in size, whereas ecchymosis is a big brother. Ecchymoses are generally more than 1 centimeter in size. Very important to note, guys, these lesions do not blanch with pressure. Okay, extravasation of blood from the vessels based on the size, particularly the smallest pinpoint lesions. Purpura is a bit bigger and ecchymosis are the largest, and they all do not blanch with pressure. All right, that's it. Now, okay, we're going to quickly go through the causes of petechiae. So basically, causes of thrombocytopenia are the causes of petechiae. And we'll go through this, right? Increased destruction, reduced production, or sequestration. Okay, those are the big branch points to think about it. And then, of course, you have dysfunctional platelets. We'll talk about that. But what are the causes of purpura and bruising? So ecchymoses and purpura. So that includes trauma. It includes thrombocytopenia. So all these causes also cause purpura, as well as coagulation disorders, which can be acquired or congenital. All right. I don't want to get too much into detail with this slide. Okay, what lab tests can be used to detect bleeding disorders? It's a question to ask. Well, blood count is reasonable, right? Because that's going to give you your platelet count. A peripheral blood smear, and we'll talk about this because that's important to exclude something called platelet clumping. And we look for specific signs on the smear, classically something called schistocytes, which are red cell fragments, and we'll talk about that. The international normalized ratio and the activated particle thromboplastin time, which tells us about the integrity of the coagulation cascade. Right, so these are all helpful in the initial evaluation of a patient with a bleeding disorder. The prothrombin time, the INR, and the APTT are helpful to identify coagulation defects. Right now, I'm sure you guys heard about an old test called bleeding time. The bleeding time is the classic diagnostic test used to identify dysfunctional platelets, but has largely been replaced by instruments that measure platelet-dependent coagulation under flow conditions, such as the platelet function analyzer, right? Some conditions may affect both platelets and the coag cascade, resulting in a mixed lab picture. Okay, so here we go, guys. Platelets disorders can be broadly divided into qualitative and quantitative. So qualitative means that the platelet number is normal, but the function is inadequate, versus quantitative, where the platelet number is obviously low. Okay, here's my first dad joke, or actually my second dad joke. Does anybody remember that joke I told about my spine? It was about a week back. You know, like week. Okay, guys. Okay, I must give you guys a warning. Functional platelet disorders are boring. I mean, like really boring, right? But we have to talk about them because it's part of the algorithmic workup. Okay, so let's get into qualitative issues which have to do with either adhesion, secretion, or aggregation problems, right? Quite boring. But anyway, here we go. First up is our beloved von Willebrand disease. Now, remember we said von Willebrand is a sticky paper that sticks your endothelium to your platelets. Well, this is an inherited condition which occurs as a result of quantitative or qualitative defects of von Willebrand factor. Now, to spice things up, I got a little bit of a cartoon here taken from MedComic. So this actually, believe it or not, is the most common inherited bleeding disorder. And as we know, von Willebrand factor, in addition to causing the stickiness between platelets and endothelium, it also is a carrier protein for factor VIII. And factor VIII is the only factor that is actually not produced by the liver. It is produced by the endothelium. Now, that is your fun fact for the day. Now, patients with von Willebrand disease present with mucocutaneous bleeding, epistaxis, easy bruising, menorrhagia, GI bleeding, you name it. And there's 3 different types, okay? Type 1, which is the most common type, is where there's actually a deficiency of von Willebrand factor, but not an absence. It's just a deficiency, right? And you can use desmopressin or cryoprecipitate to treat that. Whereas type 2 is abnormal or dysfunctional von Willebrand factor, and type 3 is where it's completely absent. So if you were to mark the register in the morning at school and say, von Willebrand, von Willebrand, von Willebrand, and nobody answers because he's absent. Okay, so basically type 2 and type 3, you use factor VIII concentrate or cryoprecipitate. Okay, I don't get too much into detail, you know. I think for us as generalists or even as physicians, that's as far as we go. Anything beyond that, we leave to the hematologist, okay? And then we have Bernard-Soulier syndrome. I told you it's going to be boring, right? Bernard-Soulier syndrome, what is this? It is a rare autosomal recessive disorder that results in impaired platelet adhesion because of a congenital absence or dysfunction of this protein called GP1B. Okay, so that's for adhesion. Two red blood cells were talking to two platelets, and one red blood cell said, "Hey, I heard that you two finally tied the clock," and the other says, "Coagulations." Okay, more boring stuff, guys. Qualitative, under qualitative secretion problems. Okay, this maybe probably not so boring. Medications. Now, which medications can give rise to secretory problems with the platelets? You guessed it, non-steroidal anti-inflammatory drugs. Your aspirin, your ibuprofen, your mefenamic acid, okay, your meloxicam, okay, your Voltaren, okay. These are among the most commonly used medications in the world, and they impair platelet secretion by inhibiting cyclooxygenase, right? And cyclooxygenase gives us thromboxane A2 from arachidonic acid. Thromboxane A2 is a powerful, mediator in clotting. All right. And remember, guys, that non-steroidals, the other place where we don't like to use non-steroidals is in the renal space. Because remember that non-steroidals inhibit prostaglandins, right? But prostaglandins mediate afferent arteriolar vasodilation. So when you give non-steroidals, you're actually mediating afferent arteriolar vasoconstriction, and you can diminish your glomerular filtration rate, which is why non-steroidals are associated with acute kidney injury. And it can actually worsen somebody who has chronic kidney injury. Just remember that. So the hematologist doesn't like too much of non-steroidals. Neither does the nephrologist like too much of non-steroidals. But the cardiologist, oh, we love those because of acute coronary syndrome, right? Because that's one of our drugs, one of the dual antiplatelets we use for acute coronary syndrome. Anyway, let's talk about uremia. Now, why do uremic patients end up with platelet dysfunction? Nice to ask, isn't it? So here is the compendium of complications of chronic kidney disease. I thought we could just spend a few moments talking about this. And all the way up here is uremia. Now, when your kidneys are failing, you can't excrete toxic substances, of which urea is one of them, right? So no surprise that you end up with uremia. And uremia causes functional platelet, well, it causes platelet dysfunction, right? Even though your platelets are normal in number, their function is not good, all right? Now, remember the other issues with chronic kidney disease is that you also end up with uremic gastritis. Okay, so these patients can bleed from there. You end up with uremic pericarditis as well. So you may have a pericardial friction rub. Now you also end up with anemia because you could be bleeding from the gastritis. Or remember that the kidneys also produce erythropoietin, and the claim to fame of erythropoietin is that it causes the production of red blood cells from the marrow. So you get anemia on that basis as well. Right? Why do you get hypocalcemia? Remember that the second hydroxylation of vitamin D happens where? Kidneys. So it's no surprise you end up with diminished vitamin D and you can't bring in calcium. So you have hypocalcemia. The parathyroid gland senses the low calcium and it liberates parathyroid hormone, which then goes out and starts breaking down bone to liberate calcium into the bloodstream. And that's what we call renal osteodystrophy. Okay. So you end up with renal bone disease. Why do you have hyperphosphatemia? Because you can't excrete phosphate. Why do you end up with metabolic acidosis? Because the kidneys can't excrete acid, right? So you end up with a high anion gap metabolic acidosis, okay? Now, also you have vascular calcification, endothelial dysfunction, which feeds into atherosclerosis. You know what the number one cause of death in chronic kidney disease? It's not arrhythmia, it's not bleeding, it is ischemic heart disease. Amazing, because of the endothelial dysfunction that we have in the setting of CKD. You also end up with dyslipidemia, you end up with hyperkalemia, which is the one that we all worry about because it can cause arrhythmias. And because you can't excrete salt and water, you end up with hypertension and fatigue edema. Chronic kidney disease is a beautiful condition to talk about in terms of pathophysiology because it touches so many aspects of physiology. But we are focusing on just one aspect today, the uremic platelet dysfunction. All righty. Okay, what else causes issues with secretion? Hypothermia. What in the world? Why do we end up with hypothermia causing issues? Well, hypothermia-induced platelet dysfunction may occur in the setting of metabolic disorders like hypothyroidism, like hypoglycemia, like adrenal insufficiency, disturbed thermoregulation, for instance, if you have an intracranial tumor, therapeutic interventions like during coronary bypass surgery or a cardiac arrest from ventricular fibrillation, and environmental cold exposure. Now, in addition to platelet dysfunction, hypothermia also causes platelet sequestration in the liver and spleen, also contributing to thrombocytopenia. The good news is that platelet dysfunction and sequestration reverse on rewarming the patient. Okay, Story's pool disease is a heterogeneous group of conditions characterized by the abnormal presence or function of intracytoplasmic platelet granules involved in platelet secretion, usually resulting in mild to moderate bleeding diathesis. Conditions include things like gray platelet syndrome, Quebec platelet disorder, Pomansky-Pudlak disease, cardiac Higashi syndrome. Okay, these are not very common, but like I said, it's part of the algorithm. Now, ever thought about what's the difference between bird flu and swine flu? Well, bird flu requires treatment, and swine flu requires ointments. Okay, guys, the last boring part about qualitative platelet issues is something called aggregation problem. Okay, once again, medication comes to the fore. So, what is the mechanism of clopidogrel? Use clopidogrel, otherwise known as Plavix. Remember, we spoke about acute coronary syndrome and we used the concept of dual antiplatelets. So one antiplatelet was aspirin, the other antiplatelet was clopidogrel or Plavix. This is a classic example of how we have impairment of platelet function by blocking the ADP, which is adenosine diphosphate, mediated platelet aggregation. Other medications that affect platelet aggregation also includes the GP2B3A inhibitors like dipyramidol and abciximab. Okay, fibrinogen disorders result from either quantitative problems like hypofibrinogenemia or qualitative issues like dysfibrinogenemia. I don't want to get into that too much. And then you probably may have heard about Glanzmann's thromboasthenia. This is a rare autosomal recessive disorder that occurs as a result of a quantitative or a qualitative abnormality in the GP2B3A. And usually you pick these early in life amongst the pediatric population, okay? Great. Those were the boring qualitative problems. Let's move on to the more clinically relevant quantitative issues with platelets, okay? So decreased production. Liver disease. Liver disease. Now, what is the mechanism of decreased platelet production in liver disease? Well, we know that the liver produces thrombopoietin, and thrombopoietin stimulates the production and differentiation of megakaryocytes into platelets. That's number one. That with chronic liver disease, you end up with something called portal hypertension, and that causes splenomegaly, and that causes sequestration of platelets in the spleen, and that's the second mechanism. Let's talk about liver disease for a bit. So I'm trying to spice things up. So let's do a bit of an OSCE kind of scenario talking about liver disease. So I'm going to give you a couple of images, and I want you guys to type in the chat box what you think are the answers. Anyway, this is the background to this. Mr. Puza is a 55-year-old male, divorced, has 4 kids, self-employed, owns 3 trucks. Well done. He was physically abusive to his wife. Very naughty, Mr. Puza. But he blames financial stress for his actions. Okay, so very naughty, Mr. Puza. Mr. Puza he owes a lot of loan shark money, which he borrowed to finance his trucks. Aibo. Mr. Puza has resorted to gambling to try to make money to pay his debts. Due to all the stress, he has been drinking 1 bottle of brandy on a daily basis for the past 2 years. Wow. A daily bottle of brandy? Wow. Mr. Puza has been referred to you by his GP with the following complaints: yellowish discoloration of the eyes. The patient only noticed this problem 2 weeks ago. Abdominal distension for the past month. And voila! Here are your examination findings, guys. So I'm going to give you about 30 seconds. Maybe feel free to type in the chat box. Maybe type in the letter of the image and what you think is the clinical sign that is demonstrated. Okay, let's go. All right, I'm getting some submissions here. A is ascites. Guys, you can type in either A, B, C, D, E, or F. So everybody doesn't have to feel free to just type in A. You can even type in F, type in D, type in C. It's all good. Okay, so A being ascites, that's excellent. E is being jaundice, that's very good, Timbela. Spider nevi coming in at D, that's excellent. Okay, now the answers are coming in quick and fast. Okay, excellent, guys. Well, I can't keep up now. I mean, it's moving too fast. But I see a lot of correct submissions, okay? So A is ascites, as you know, you correctly pointed out. So you're going to do shifting dullness, and the shifting dullness will be present. Okay. B is something called leukonychia. Now, why do you get white nails? Because of hypoalbuminemia, right? This is the Dupuytren's contraction, right? It's actually fibrosis of the palmar fascia. And this is a sign which is unique to alcoholism, okay? Now, D is spider angiomata or spider nevi. Okay. And E is jaundice, and F is paratidomegaly. So paratidomegaly and Dupuytren's contracture speak strongly to alcoholism, whereas everything else speaks to cirrhosis or chronic liver disease. Now, I don't want to talk too much about this, but why do you end up with testicular atrophy and gynecomastia and axillary alopecia? It's because of the abnormal ratio of estrogen to testosterone. So remember that the liver normally converts estrogen to testosterone. But if the liver is not working nicely, you have preponderance of estrogen. And estrogen is a very vascular hormone, which is why you end up with spider angiomata. And also why you end up with testicular atrophy and axillary alopecia, because there's not enough testosterone. There's too much of circulating estrogen. All righty. Okay. And remember that the reason why these patients have platelet problems is because, number one, there's not enough thrombopoietin. And number two, there's sequestration of platelets in the spleen because of portal hypertension. The portal hypertension happens as a consequence of cirrhosis. Very good. Okay, marrow hypoplasia. Now, bone marrow hypoplasia can be transient or permanent, the latter of which is referred to as aplastic anemia. It is usually associated with pancytopenia, not just thrombocytopenia, but pancytopenia. Causes of bone marrow hypoplasia include medications like linezolid. Ooh, linezolid sounds very familiar. Where have we seen linezolid before? Or maybe TBC, right? Not first line. Toxins like alcohol, infections like parvovirus B19, and pregnancy. Most cases of aplastic anemia are idiopathic, all right? Ineffective erythropoiesis, okay, this describes the failure to produce mature blood cells as a result of dysfunctional progenitor cells, despite the presence of normal or hypercellular bone marrow. It is also often associated with pancytopenia. Causes include megaloblastic anemia and myelodysplasia. And maybe the marrow is infiltrated. Bone marrow infiltration describes the replacement of hematopoietic stem cells. It is usually also associated with pancytopenia. Causes include malignancy, especially acute leukemia. Don't forget acute leukemia. Infection like disseminated TB, T to the B, T to the B, TB, right? And myelofibrosis, okay? Bone marrow infiltration leads to extramedullary hematopoiesis, which is associated with characteristic peripheral blood smear findings, including giant platelets. You know, I like dad jokes about the eyes. The cornea, the better. Also, have you ever thought about why eyes make such good teachers? Because they only have one pupil. All righty, guys. So we spoke about decreased production. What about increased destruction of platelets? Now, this is where it gets really interesting. Hypersplenism. Hypersplenism. What is this? It refers to the combination of splenomegaly, peripheral cytopenias, and normal or hypercellular bone marrow. One more time, hypersplenism is a combination of number one, splenomegaly, number two, peripheral cytopenias, and number three, normal or hypercellular bone marrow. Massive spleens are capable of secreting up to 90% of peripheral platelet mass. Partial splenic embolization can be helpful in treating thrombocytopenia of hypersplenism. But guys, there's a couple of pointers, right? Now, let's go back to the bedside, talk about clinical examination. It's very important to be able to have the correct technique for palpating the spleen. Now, the spleen, remember, enlarges inferomedially in adults, whereas in kids, it goes straight down inferiorly. So when you start palpating for the spleen, you want to start in the right iliac fossa, and you move diagonally upwards towards the rib cage on the left, okay? The correct technique is to use your left hand and hold the skin taut while you're palpating upwards, okay? And so if you can't feel the spleen, but you're not really sure, what you can do is turn the patient towards you in the right lateral position. You can bend the knees and feel again. And if you still can't get it, you can percuss in what we call Taubes space. Now, Taubes space is the space between the anterior and the mid-axillary line and between the sixth and eighth ribs. If you get dullness on percussion, there's probably an underlying spleen, okay? This is to illustrate how the liver enlarges inferiorly, but the spleen in adults enlarges inferomedially in adults, but it goes straight down in kids. Okay. And the other question they love to ask in the clinical exam is, do you know what you are feeling is the spleen and not the kidney. So there are 7 points you should know: that the spleen is in the left hypochondrium, whereas the kidney is in the left lumbar area. The spleen moves with respiration towards the right iliac fossa, but the kidney moves downwards and forward. The spleen has a definite medial border, but the kidney is more round in shape. The notch happens with the spleen, but not with the kidney. With the spleen, you can get above the swelling. Um, I beg your pardon. So you can't get above it because it's retroperitoneal, but you can block the kidney. On percussion, there's dullness over the spleen, but there's resonance over the kidney, and the spleen is palpable, but the kidney is palpable. So these are the big 7 that we usually expect from the students in the exams, and even in postgrad exams as well. You think you may remember it, but it's amazing how the stuff comes back, and then you're like, I knew it, but now I forgot it. Okay, and very important, guys, the spleen must be enlarged 2 to 3 times before it can be felt. So once you can feel a spleen, you are sure that it is enlarged. And the way we stratify our approach between mild, moderate, and large depends on the size of the spleen. So you've got to measure the axis of the spleen. Okay, and we look at that here. Look at this. When you're thinking about causes of splenomegaly, you divide it into massive, moderate, and small. The massive means it's 8 centimeters or more. And the common causes are chronic myeloid leukemia, idiopathic myelofibrosis, and chronic lymphocytic leukemia. Do not forget tropical malaria syndrome. If malaria is endemic, and it is kind of endemic to parts of KZN, and we also have a lot of visitors coming from Mozambique, any travel history together with a massive spleen, you've got to think about malaria, guys. Okay, Kala Azar doesn't happen here; it happens in Asia, but primary lymphoma of the spleen is another differential. Then moderate splenomegaly between 4 and 8 centimeters includes all of the above, plus portal hypertension in the context of cirrhosis, plus other kinds of leukemia, plus storage diseases. And do not forget infective endocarditis, and do not forget Felty's syndrome. What is Felty's syndrome? It is a triad of rheumatoid arthritis with neutropenia, splenomegaly, and you have leg ulcers as well. Then small splenomegaly, which is 4 centimeters or less, is all the above, plus things like polycythemia, hemolytic anemia, megaloblastic anemia, connective tissue issues, okay, the Epstein-Barr, cytomegalovirus, all the viral infections, etc. So this is the way for those guys going in for clinical exams, okay? So I thought I'd use this opportunity to speak a little bit about malaria. There's different kinds of malaria we get, guys. There's Vivax, Ovale, there's Malariae, there's Falciparum, but the deadliest one is Falciparum malaria. And what do we have in sub-Saharan Africa? The deadliest one, Falciparum malaria. All right. Now, how do you define clinical features of severity? Well, something called cerebral malaria. The patients come in with seizures, they have impaired consciousness, they have prostration where they're unable to sit, stand, they can't even walk without assistance, convulsions, they are acidotic, okay? They have acute pulmonary edema. Now, another name for this is acute respiratory distress syndrome, okay? It's not cardiogenic. This is non-cardiogenic pulmonary edema, okay? Some of them come in with hypotension and circulatory collapse. They end up with acute kidney injury because of diminished renal perfusion, and they come in with anuria, jaundice. Some of them have this thing called black water fever. Because of the massive hemolysis, you end up with hemoglobinuria, and the urine literally looks black water fever, okay, abnormal bleeding. Lab criteria, hypoglycemia on account of the severe septicemia, metabolic acidosis because of the AKI and because of the hyperlactatemia from the organ hypoperfusion, severe normocytic anemia. Now, we look at a parasite load of above 4% to say that it's severe, hemoglobinuria, which is black water fever, hyperlactatemia, renal impairment, pulmonary edema, right? So there's lots of things which help you to determine if the malaria you're dealing with is severe malaria. And how do we manage this? You support the organ that's failing, and you give the patient artesunate, IV artesunate, and once they show improvement, you can then move them on to coartem, which is artemether lumefantrine. Alrighty, so that's a little bit about hypersplenism, guys. The next heading is something called immune thrombocytopenic purpura. What is this? Okay, so let's talk a little bit about pathogenesis of ITP. So you get these antiplatelet antibodies which come and they cause opsonization of the platelets, and they're then taken up by the reticular endothelial system, the spleen and the liver, which basically chow up the platelets. Okay, and you also have antibody-specific suppression of the platelet precursors in the marrow. All that leads to immune destruction of the platelets, all right? Diminishing the lifespan of the platelets. And the bone marrow now, poor bone marrow, tries to increase production of platelets because it's being destroyed peripherally so fast. And the platelets it produces tend to be very large. Right? So you have immature, large platelets. Now, amazingly, patients with ITP are not very sick. They can be walking around as outpatients with platelet counts of 20 and 30, and they seem fine, right? And this is different from DIC and TTP because those patients are very sick. But ITP patients are relatively well. And they rarely have serious bleeds like intracranial bleeds, but they can have petechiae, purpura, ecchymosis, mucosal bleeding, etc. Okay. Now, very important, guys, that we have acute and chronic flavors of ITP. Acute ITP occurs within 3 months, more common in kids, but chronic ITP more common in adults. All righty. Now, if you are in the internal medicine space and we make a big deal about how you treat ITP, remember that ITP is a diagnosis of exclusion. So you can't say a patient has ITP and you didn't investigate them for other etiologies, right? ITP is the one that you diagnose by excluding all other pathologies. How do you treat it? Corticosteroids, okay, dexamethasone is proven to have equal efficacy as compared to prednisone. If that is refractory, you can consider IVIG, so polygam, that's intravenous immunoglobulin. And then other therapies, new stuff on the market, you can use rituximab, which is anti-CD monoclonal, anti-B cell antibody. You can use thrombopoietin receptor analogs like thrombopag and romiplostim, which are expensive but very effective. But that's for refractory ITP. Okay, yeah, thrombotic microangiopathy. Ooh, ooh, ooh. So thrombotic microangiopathy essentially comes in different types, but the main two we concern ourselves with is with disseminated intravascular coagulation and thrombotic thrombocytopenic purpura, DIC and TTP. Hemolytic uremic syndrome is closely associated with TTP. Okay. Now, DIC, I think I've got another slide on DIC, but it's called a consumptive coagulopathy, often happening in the setting of severe sepsis, where you have activation of clotting, consumption of platelets, and activation of clotting at the same time. It's weird because you've got low platelets, but they're actually prone to clotting and bleeding. Okay. And let's talk about this a bit. The hallmark features of your microangiopathic hemolytic anemias is that you have this thing called schistocytes, which are also called red cell fragment that you see on the peripheral blood smear. And you end up with hemolysis. Now, hemolysis means the breakdown of red blood cells. How will this manifest on your labs? So your hemoglobin is going to be down. Your unconjugated bilirubin is high. Why? Because you're breaking down red blood cells and you're elevating your unconjugated bilirubin, right? Your haptoglobin now, we spoke about haptoglobin during our lab masterclass. Haptoglobin is kind of like the mop, which mops up all your free hemoglobin. So because you got so much of free hemoglobin because of hemolysis, your haptoglobin goes down. Fancy. Your lactate dehydrogenase is going to be up. Your reticulocyte count is going to be high, provided your bone marrow is functional. Your Coombs is going to be positive if it's autoimmune, and your smear is going to show you schistocytes. That is how you work up hemolysis. Now, remember that the microangiopathic hemolytic anemias are going to have hemolysis together with features that we discussed now on DIC and TTP. So let's zoom into TTP a bit. So there is this protein called ADAMTS13. It's the full thing is a disintegrase and metalloproteinase with thrombospondin 13-like motif, right? But the acronym is ADAMTS13. The whole function of ADAMTS13 is that it breaks down your big multimers of von Willebrand factor. But in TTP, what happens is that there's a deficiency of ADAMTS13. So you have too much of von Willebrand factor, and too much of von Willebrand factor causes ting. And these clots, what they end up doing is trapping the red blood cells. As the red blood cells go past the clots, they shear. And as they shear, they humanize. Okay? So that's basically the underlying pathophys. And because of the widespread clotting, you end up with clots in various organs. So it gives rise to end organ dysfunction. So if that happens in the central nervous system, you get confusion, you get seizures, you get focal neurological deficit. If that happens in the heart, you end up with arrhythmia, sudden cardiac death. If you have it in the kidneys, you end up with proteinuria and acute kidney injury, right? So intuitively, all this stuff kind of makes sense. Widespread activation of clotting because there's not enough ADAMTS13, and as the red cells pass the clots, they shear and they hemolyze. And because you've got widespread activation of clotting, you have end organ dysfunction because of ischemia and infarction of those various organs. Now, there is something called hemolytic uremic syndrome, which is basically an E. coli infection, the specific serovariant called E. coli 0157H7, which produces something called sugar-like toxin. And sugar-like toxin actually depletes your ADAMTS13, which gives rise to the same situation. But the kidney impairment in HUS is usually more severe than in the run-of-the-mill TTP. And this usually happens in the younger folks and in the pediatric population, whereas normal TTP happens more in adults. Okay, now if you like acronyms, I love acronyms. Uh, Remember, partner. And the reason I put a diaper in there is because diarrhea, right? Diarrhea, you need diapers. Okay. P is platelet count is low. A is anemia, being microangiopathic hemolytic. R is renal failure. T is temperature rise. N is neurological deficit. E is emergency. But I also like this one, fat RN, a fat RN. F is fever. A is anemia. T is thrombocytopenia. R is renal impairment, and N is neurology. Now, not everybody has the pentat. Sometimes you may have only 3 of the 5 features, but it's important to recognize if these things are happening together in the same patient, you cannot not consider PTP in your differential, okay? Fever, anemia, thrombocytopenia, renal impairment, and neurology. Okay, so DIC, disseminated intravascular coagulation. Usually we see this in the setting of severe septicemia, okay? So, and also malignancies can do it. There's systemic activation of the coagulation cascade, and you diminish your fibrinogen, okay? So, but like we said, consumptive coagulopathy, you have activation of clotting, depletion of your clotting factors, and bleeding as well, right? You end up with increased D-dimer because of fibrin degradation. You end up with thrombocytopenia because of activation of clotting. You end up with the MAHA and schistocytes, once again, multi-organ dysfunction, but you have a high INR and a high PTT because it's a consumptive coagulopathy, as opposed to TTP, where you have a normal INR and a normal PTT. Now, that is the big point of departure. Now, I'm going to go through a table which compares DIC with TTP with ITP so that we are familiar with that. So, what sprinters eat before a race? Nothing. They fast. They fast on it. Okay, robotic microangiopathy. Okay, I think we've been through that. Heparin-induced thrombocytopenia. We've got to hit that one. Is a hit, quite a hit, HIT. So, we're very fond of using inoculopathin sodium, which is Clexane. Sometimes we use unfractionated heparin for thromboprophylaxis. Right? We don't want our patients to end up with DVTs and PEs in the ward. But heparin is not the safest drug. It's not as safe as you may think, okay, because we have HIT type 1, HIT type 2. So HIT type 1 is basically the more indolent form, is not as harmful. Okay, it drops your platelets, but not that low. And not enough platelets are activated to cause significant thrombosis, right? Whereas with HIT type 2, heparin binds to this thing called platelet factor 4, right? And that then, the IgG binds to the platelet factor 4 complex, and that leads to the platelets being removed by the splenic macrophages. And this usually doesn't happen immediately. There's usually a lag of about 5 to 15 days from the time it starts the heparin, right? But ultimately, that also triggers clotting as well. They end up with low platelets, but it also triggers clotting as well. You have fever, you have flushing of the skin. So it's important for us to consider this when we have a patient with a normal platelet function. We started the Clexane, and then thereafter you find that the platelets drop. Okay, so there's a temporal relationship between the Clexane and the thrombocytopenia. So that's how you pick that one up. Now, this is a beautiful table. So I encourage you to snapshot or screenshot this one, because this one is what they love to ask, especially in the internal medicine exams, whether it's a diploma or whether it's the FCP, right? So how do you tell the difference between these entities? Let's have a look. TTP, endothelial defect, right? Adam TS13, we went through that. DIC is a consumptive coagulopathy, thrombin excess. ITP is antiplatelet antibodies. This is the thing I was talking about, guys, that patients with ITP are not sick. They're walking around, they're chilling, they're having a good time. They're coming into your outpatient clinic and they're talking stories. They are well. But TTP and DIC patients are sick. Okay. Now, both TTP and DIC will have schistocytes, which is called red cell fragments on the peripheral smear. ITP does not. Okay. Your INR, your partial thromboplastin, your fibrinogen, your fibrin monomers are all abnormal in DIC. Look, abnormal. But TTP, these parameters are normal. Okay. And your management, TTP, we use plasma exchange. You can use IVIG. You can use steroids as well. DIC, the management is treat the cause. If there's malignancy, you start chemotherapy. If there's sepsis, you treat the sepsis, okay? ITP, we went through the treatment. We said steroids, we said polygam, we said splenectomy, we said thrombopoietin analogs, we said rituximab. All righty. Okay, guys, now practical point. How are we doing for time? Okay, almost out of time. It's 25 past 7. Practical point, guys. In general, when should we avoid Clexane? So if you work in the ward and you're thinking, okay, what are the times when I don't want to use Clexane? Well, in general, when your platelets are below 100 and when your INR is above 2, because those patients are prone to bleeding, okay, and that's when you don't want to use it. The other part is renal impairment. When patients are renally impaired, you don't want to stop the Clexane, but you want to dose reduce the Clexane. Okay, so if you're doing prophylactic, ideally you want to do slightly less than 0.5 milligram per kg. You do about 0.3 to 0.4 milligram per kg, which is about 20 to 30 milligrams instead of 40 milligrams per day of subcutaneous Clexane. Okay, and then another practical thing. So you say, doc, you know what, my patient's platelets are low, but how low can you go? When do you want to transfuse the patient platelets? Good question. Okay. So in general, anybody who has a platelet count of below 10, irrespective of whether they're bleeding or not, you should transfuse them platelets, right? If you're considering surgery with active bleeding, you want to transfuse them if the platelet count is below 50, usually below 50, if they're going into theater. Okay. Even if you're doing some kind of invasive procedure at the bedside, like a liver biopsy or a bone marrow biopsy, ideally you want the platelets to be, okay, bone marrow you can do above 20 is safe, but probably things like more invasive, especially surgical procedures, you have to have a platelet count above 50. Okay, otherwise, yeah, if they stable, non-bleeding, pyrexial, undergoing invasive therapy, invasive is like a central line or like a HD catheter insertion, ideally you want the platelets above 20. All right, so these are basic guidelines, guys. This is taken from the American Society of Hematology. I got this from GrepMed, the website, but these are just general guidelines, okay? Okay, so this is everything we spoke about in a nutshell. Platelet disorders divided into qualitative and quantitative. Qualitative has to do with adhesion, secretion, and aggregation problems, and we touched on the von Willebrand and Bernard Soulier. Secretion, we said, is medication. We spoke about aspirin. We said uremia, hypothermia, Forest pool disease. Aggregation, we spoke about medications, and then we have your ADP receptor antagonists, your Plavix. We spoke about fibrinogen disorders and Glanzmann's. Then quantitative was the more interesting part of things. We said it's because of liver disease, because of diminished thrombopoietin, and because of hypertenism, marrow hypoplasia, ineffective thrombopoiesis, and marrow infiltration. Then destruction is where we introduced hypersplenism, and we spoke about that. Then we went to speak about the difference between ITP, DIC, and TTP, and how to tease those apart. And we spoke a bit about heparin-induced thrombocytopenia. All righty. We also spoke about malaria as well. We typically touch on thrombocytosis, which is the opposite thing. Thrombocytosis is too much platelets, and they were divided into primary and secondary. Now, most of the thrombocytosis we see is secondary or reactive in the setting of acute infection or malignancy or anemia, and I don't know if you guys noticed, patient is iron deficient. You often have a low HB with a high platelet count. I don't know if you guys noticed that, because it's a reactive thrombocytosis with iron deficiency. It's one of the things you can actually tell by looking at the FBC whether the patient actually has iron deficiency, because often the low HB is accompanied by a thrombocytosis. And that's before you get the iron studies, right? Chronic inflammatory disorders can do it, post-splenectomy can do it. But the primary issues, you think about essential thrombocythemia or as part of polycythemia vera. For more on this, guys, we speak about this during our hematology masterclass, and we also touch on this during our lab masterclass, which are two other offerings that we have on the clinical care platform. Okay, did you know that you can get paid for sleeping? Paid for sleeping? Yeah, it's a dream job. And that's what Brother Mawela was doing before this webinar. He was catching a few 40 winks there. Okay, guys, let's do a test. Okay, now let me tell you a story. This was a patient that I saw in the ward. It's actually a real case that I saw some time back. And this patient was well. I mean, came into the follow-up clinic for some, I can't remember the reason, but it wasn't related to bleeding. Okay, and this was the FPC, Weissler count of 7.84, which is normal. 22.3. What is happening here? So obviously you're thinking about polycythemia, right? So your knee-jerk reflex is to look at the hematocrit. Hematocrit is high. Okay, And the platelet count is 88. I'm thinking, no, what is happening? This patient is so well. Differential count is shown here. Okay. Then, okay, so yeah, we're focusing on the platelet count of 88 now, right? Which obviously is low. Now, the first question is my patient on Clexane? And the answer is no. She's an outpatient. I'm seeing her in the clinic. Okay, she's not on Clexane. Secondly, is she symptomatic? Is she bleeding? No, she's walking around. There's no menorrhagia, no epistaxis, no hematuria, no hemoptysis, no bleeding whatsoever. Now, next question. Are those platelets plump? So I needed a peripheral smear. The peripheral smear will tell me if there's clumping and will also tell me if there are red cell fragments. And this is the peripheral smear. It says, okay, polychromasia, which means red cells of different colors, or colors, but diminished with different hemoglobin concentrations, right? Poikilocytosis is different shapes, some elliptocytes, some bite cells, some scanty target cells, okay? Importantly, it tells me, hello, doctor, no platelet clumping. So this is true thrombocytopenia, platelet count of 88, no platelet clumping. Note that it does not tell me schistocytes. It does not tell me red cell fragments. So when I don't see schistocytes, I know that it cannot be DIC and it cannot be PTP, right? And it cannot be clumping and it cannot be hit because the patient's not on Clexane. Alrighty. So we're doing a process of elimination here now. I'm thinking to myself, okay, could it still be DIC? What am I missing here? Right? So I asked myself, what's the INR, what's the D dimer, what's the PTT, what's the fibrinogen? And the INR came back plumb normal, 1.10. I'm thinking to myself, okay, now it can't be DIC. I'm asking myself, is there renal impairment? Because renal impairment would point to TTP. Remember we said fat RN, fever, anemia, thrombocytopenia, renal impairment, neurology. But this was the UNE. The UNE looks pretty normal to me. I don't know what you guys think. EGFR of over 60. There's no renal impairment. There's a normal INR. Something doesn't make sense. Is this ITP? That was my so see how we are ruling out all the possible pathologies, and then we consider ITP last, but we said it's a diagnosis of exclusion. So because the wonky HB, I have some reservations because the patient didn't show any clinical signs of polycythemia, did not have corpulmonale, did not have conjunctival suffusion, wasn't overloaded as you would expect someone with a hemoglobin of 22 to be. The patient's a non-smoker, okay, and there's no family history of blood dyscrasias. So, I was very skeptical, so I repeated the full blood count. And this is the repeat FBC, white cells of 11.1 with a normal platelet count. So the first result that I saw was a spurious blood result. It may not even have been that patient's bloods. Maybe it was somebody else's bloods. So the take home for me from there was always trust your guts. Because clinically, if the patient didn't look plethoric, didn't look polycythemic, HB of 22 can never be correct. Okay. And this patient actually had a normal platelet count. Yeah, okay, slightly microcytic hyperchromia. We can talk about that. But the main thing for me is that the platelets were normal. So there is value in repeating a blood test if something seems like it just doesn't quite add up or make sense. As I put my car into reverse, I thought to myself, this takes me back. Yeah, well, reversing your car does take you back. Okay. Okay, everybody. So I just want to talk a little bit about the other offerings we have on the CCP from internal medicine. As Brother Mawela mentioned, in October, we kick off with the Diploma Internal Medicine Program, and this is on the itinerary. So all of these are based on past year papers from the college, and obviously I populate that with my own lectures and my own material, and we have even an MCQ bank as well to go with that. Together with OSCE, I even give you guys advice about the clinical as well. And we include 2 workshops here, the ECG and the chest X-ray masterclasses as well. Then, of course, this year has been a hectic year because we've run up the FCP2 masterclasses. We had targeted masterclasses on Saturdays covering each of these specifically. That's what we also offer on the CCP. We've got a lab analysis masterclass where we talk about these topics, hematology, and then we have non-hematology topics. So everything from blood gases to TFTs to inflammatory markers. Here's an example of a slide from there talking about TFT interpretation, how to go about ordering TFTs. Then we have the mechanical ventilation workshop, and we cover a whole lot of topics from the physics and the introduction to the concept of mechanical ventilation, all the way to ventilator modes and options and consequences. And we also have online vents which we will demonstrate in terms of troubleshooting and setting up the vent. Okay, and this is an example of capnography that we covered during that particular talk. Okay, this is an overview of ventilator modes, and we go through each of these, how to set up the ventilator. Okay, so that's A to Z of mechanical ventilation. Then, of course, we have the ECG masterclass, which is one of the favorites on the platform, introducing you to how to set up the ECG, how to interpret the ECG, different aspects of ECG interpretation, application clinically. This is an example of different ischemic territories and how to interpret those. Then, of course, we have the chest X-ray masterclass as well, the A to Z of chest X-rays. This is an example of one of those slides. And of course, last but not least is my YouTube channel. So if you love internal medicine, I strongly encourage you to have a look at my channel called Internal Medicine Algorithms and Mnemonics. I have more than 500 videos on a variety of topics. So I'd love to have your friendship there on my channel. Here's an example of one of my offerings, medications in Parkinson's disease, carrot salad. Feeling hungry now. Okay, how do you make the number one disappear? Just add G and it's gone. See? Add G to one. Okay, I think I'm overdoing it now. Okay, guys, remember the case? Say this gentleman was waiting for us for so long. We're coming back to him now. It was a healthy 39-year-old male, came in with fever and confusion. He had dependent petechial and purpuric skin rash. He had thrombocytopenia. He had renal dysfunction, evidence of hemolytic anemia with an abnormal peripheral smear. This was the smear, remember? And these are called schistocytes. They are abnormal red cell fragments. Now, you put everything together, he's got renal impairment, he's got thrombocytopenia, he's got evidence of hemolysis, he's got an abnormal smear, which shows you schistocytes. What's the likely diagnosis? Do we have any submissions here? TTP, 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 TTP. Well done. Excellent job, everybody. Okay, this is your doggy bag of takeaway points, guys. Platelets are produced in the marrow and destroyed in the reticular endothelial system. They have a lifespan of just 9 days. They are important for the integrity of the vascular system and for achieving primary hemostasis. Clinical manifestations are easy bruising, excessive bleeding, petechial and purpuric rash. Disorders can be either qualitative or quantitative. We said qualitative is a problem with function, whereas quantitative is a problem with number. And that's what we call thrombocytopenia. We said, okay, the image of, we didn't talk about it too much, but I don't think it's that really critical in terms of our understanding. And yeah, these are my references, everybody. Platelet disorders, Brother Mawela.
Awesome, 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 awesome. What a great one, Brother Ryan. To respond to your questions. Brother Ryan, maybe we can start with my questions. Just one. I wanted to just ask, in your clinical practice, how do you respond to I don't okay, firstly, do infections like TB present with isolated low platelets? Is that something that can happen, or it's always in the context of all other cell lines being affected?
Yeah, brother. It's usually a pancytopenia with
Yeah,
maybe even a bicytopenia, but really
yeah.
just the platelets. Really just the platelets. Yeah, correct. Because that's disseminated TB, right?
Yes,
Mm.
yes. And how is your approach in that setting? And I'm asking in the context of, if you treat for TB, do you generally see most of your patients recovering? Have you had to replace platelets in a TB context?
No, not really, brother.
No. Yeah.
And usually these patients have very low CD4 counts. Some of them come
Mm,
in with overwhelming septicemia, and it's a
mm,
multifactorial picture. So it's a severe
mm,
sepsis that's driving the platelets low. So we give them antibiotics, we give them
mm,
fluids that treats that
mm,
aspect. We start the
mm,
TB treatment. Then somehow together, synergistically with the ARVs, they just
mm,
boost their counts up on their own. Yeah.
mm. There's a nice question for you, because I know you are an awesome clinician, physician. How do you differentiate a kidney from a spleen clinically? Half of my patients have high truncal So especially in a bit people who are a bit obese, yeah. But I know it's a nice internal medicine.
Yeah, brother.
Question.
No, that's an honest question. It is an honest question.
Yes.
And nowadays,
Yeah.
brother, we kind of we rely on imaging a lot, to be honest.
Yeah. Yeah.
So in such patients, we go to the ultrasound. If we
Mm,
suspect the spleen is there, but we can't feel it, we say, "Hey, ultrasonographer, help me
mm,
out." And then they do
mm.
the ultrasound, and they will actually pick up the splenomegaly on the ultrasound. So
Okay.
yeah, raised BMI is always a challenge. It is.
Mm, mm. Yeah, so I think the colleagues use your clinical skills where you feel like there's limitations. In the modern era, there's imaging, and people even have portable ultrasound probes. Some of them you can connect to your iPhone. I don't know about banana phones, but yeah, and then you see you see what's happening there. So Hanan says, can you explain heparin toxicity symptoms? How would they pick it up?
Heparin toxicity symptoms.
Yeah.
You mean heparin-induced thrombocytopenia, right? Uh,
Yeah, I think that was when you were talking about that, because obviously there's a
yeah.
timing on this question, just that it's a bit difficult. Yeah.
Oh
Yeah.
yes, yes. So
Yeah.
so there's two types of hit type 1 and hit type 2. The hit type 1
Mm,
is the safer one. It happens almost immediately, and
mm,
usually it resolves on its own. So you can
mm,
actually continue the clexane there. And the platelets come down, but really below 50,000. But with HIT type 2, that's the one that involves the antibody to the platelet factor 4 complex. It manifests within 5 to 15 days after starting the clexane. And there your platelet count drops very low. And there you have to stop the clexane. Yeah.
okay. Okay, awesome. Hanan, do let us know in the chat if you are good, even it's a thumb or just a yes, or even a follow-up question. We still have a good time. Dr. Kamohelo says, what is the role of fragments on the smear in differentiating TTP from DIC? Probably seeing that other things are not conclusive in under certain conditions. Yeah.
That's a good question. So remember,
Mm,
Doc, that both DIC and TTP will give you fragments. But
mm,
with DIC, your INR, your fibrinogen, your D-dimers will be abnormal, but they are
mm.
normal in TTP. So that's how you differentiate them. Both are going to give you fragments, but the other bloods are abnormal only in DIC. They are normal in
Okay.
TTP. That's how you tell
Okay.
that apart. Yeah.
Okay. Okay. So I think Kamohelo, maybe that last part where he thought both would be high, and R&D demos would be high. That's the part that needs clarity. Yeah. Thanks for picking up on that, brother Ryan. David is just appreciating, says, "Yo, thank you so much for taking such a challenging topic and cutting it into pieces, Dr. Ryan. We appreciate it."
Very welcome, brother.
Yeah. And then he had a follow-up. He says, and this is just after that comment to say he actually had a female with platelets of 18 at a local clinic. Maybe the question, Brother Ryan, compared to males, are there any considerations, special considerations in terms of evaluating the same conditions in females? Do females bring a different view to the problem?
Mm, yeah, well, the obvious one, females can bleed from one other place, right? They can
Mm,
bleed no, from the genital tract. So they can end
mm,
up with menorrhagia and very severe bleeding. And then there's a whole
mm,
question about, is the menorrhagia driving the low platelets, or is the low platelets driving the menorrhagia? So
mm,
the key there is to go and get yourself a pelvic ultrasound scan and look at
mm.
their
Okay.
anatomy. Is there anything? Is it endometriosis? Are there fibroids? Is there something else that's
Mm,
causing the propensity to bleed? And then we're going to use a dual approach. You can transfuse
mm.
platelets, and you can deal with the gynae pathology. So both disciplines will work together in that
Together.
respect.
Yeah.
Yeah.
Awesome. Awesome. Anonymous is asking, I suspect he wanted to say splenectomy. Because
Yes.
I doubt it will be splenomegaly still as treatment. I suspect it's splenectomy. Would you
Mm.
like to comment on that? Yeah.
100%. Uh, Excellent question. So hematology guys, they like to go to splenectomy as a last resort. And now
Mm,
with our pharmacotherapy improving day by day, we have more
mm,
options as in times past. So whereas in the
mm.
70s and 80s they went straight to splenectomy, now we don't do that commonly. We
Okay.
use the drugs that we mentioned, especially the thrombopoietin analogs. Those are gaining ground. So yeah, rituximab as well.
Okay.
So last resort.
Awesome.
Mm.
Awesome. Okay. We can read it together. It's a scenario
Mhm.
by Dr. Jean there. Let me see if I can, if there's a way of me getting, just give me a few seconds, brother, right? I want to reduce the size of this thing.
No problem.
Yeah, I hope you can see it, but it says it's a 19-year-old female with menorrhagia, has worsening thrombocytopenia of 86 on admission, and then 2 days later is 45, and then now 25. So there's a decision between the
Mm.
two departments, right? That the cause of the menorrhagia is the thrombocytopenia.
Mm.
Yeah, I think it's trying to ask you which one causes which. Chicken and egg. How?
Oh dear. Okay, so my
Uh,
question, brother John Jacques,
yeah,
Kalamba. Yeah, my question
Kalamba
is,
Mongole clause. Yeah.
so from the gynae side, right? I'm sure pregnancy is excluded. And did you do a pelvic ultrasound? Did you do a pap smear? Did you clear the patient from gynae pathology? Did you start her on oral contraceptive, which is how we deal with abnormal uterine bleeding? So if you're happy
Mm,
from your side, but she's continuing to bleed, then she becomes a medical patient. Because then we have to take over and figure out what's driving the thrombocytopenia.
mm,
So if there's nothing that you're going to intervene on from the gynae side, and you're
mm,
happy, you start her on contraceptives, you've done the pelvic scan, then she belongs to internal medicine to investigate.
mm,
So we will do all the panel of bloods, even including a bone marrow if necessary. But yeah,
mm,
that would be my advice in that context.
mm. Awesome, awesome, awesome. Hey, Joy. Joy says, "Are you a working Mac manual? Make manual on, on just appreciating the knowledge you share. But this one is a make manual with a bonus because you just keep us laughing. You see how energized I am. You see, I'm like, woo. What did you say? The one joke? How do you remove a one or something? Add a G. Gone.
Yes, yes. Well, brother, how about this one? I got another one for you, right? So
Uh-huh.
I am an odd number, but if you remove one of my letters, I become even. What am I?
11. I don't
Mm,
know. Or you become
It's
even.
seven.
You become
It's
even.
seven. It's
Seven.
seven.
Oh, you remove the
Uh,
the S.
The S.
And you
Yes.
get even. Ah, I got it all
Yes.
wrong. Hey, colleagues, you can see these riddles. Yeah. Oh, on Tuesday, brother Ryan, I had a
Yes.
similar thing. I said there are five frogs,
Yes.
and four of them decide to jump into a river. How many are left? People say one, 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 one. I said no, but deciding to jump is not the same as jumping. It's still five. That was on Tuesday,
That's a
talking
good one.
about taking action. Deciding to take action and taking action is not the same.
Amen.
I don't know if
Mm.
Philip's question needs more clarity, but because I don't know, but let me ask it as it. How low are platelets in DIC? I don't
Ooh,
know if,
it's very low,
yeah,
Philip. But in general, they
yeah,
can go all the way down to like
yeah.
5 or even 10, you
Mm,
know. And the other thing, brother, is with DIC, because it's a consumptive coagulopathy,
mm,
transfusion doesn't work because you give the platelets
mm,
assistance, they get chowed up, right? So
mm,
the management of
mm,
DIC is to sort the cause. If there's
Mm.
septicemia, you give the antibiotics, you do source
Deal
control.
with it.
If there's
Mm.
malignancy, you do chemo, you do radiotherapy. So
Mm.
transfusion is probably not going to work. But yeah,
Mm.
platelet can go all the way down, Brother Philip.
Yeah, maybe if you can help, because I'm linking this to the previous question where the colleague thought both would have high INRs and stuff. Can you remind the colleagues on DIC what are the key features that would say this is DIC? Because I mean, it's not about how low the platelets are, right? Yeah.
Absolutely. So with DIC, I think number one, what's happening with the patient? Are they septic or do they have a malignancy? Right.
Mm.
Then the second
Mm.
thing is your platelets are low. Right.
Mm.
The third thing is that on your peripheral smear, you're going to see schistocytes. So you
Okay.
know it's a
Mm.
microangiopathic process. Right.
Mm.
And the next thing is that the other bloods, the D dimer is going to be high. Fibrinogen is
Mm.
going to be low. Your INR
Mm.
is going to be high. Your PTT is going to be high. In the setting
Mm.
of schistocytes, in a patient who has an underlying illness, it's
Mm.
DIC. But
Okay.
TTP is where you have schistocytes together with the, I can remember, fever, anemia, thrombocytopenia, renal impairment. Uh, but there you have a normal INR, normal PTT, normal D dimer, normal
The
fibrinogen.
dimers. Mm. Mm.
Yes, all that is normal with
Okay.
TTP. And
Okay.
ITP, you won't even have schistocytes on the smear. You just got low platelet,
Mm.
and the patient is well. They're not sick.
Yeah, they are mom-
Yeah,
they are working. Colleagues, did you
walking.
get that? I think that is at the crux of today's workshop. Do show us with a thumbs up to say, yeah, yeah, thanks for that quick revision again. We're going to continue for the next 3 minutes. So let's see. Josephat says, in liver cirrhosis, oh, he wants a tip on the management of thrombocytopenia in liver failure or liver cirrhosis. Like, are there specific things you can do there? Yeah,
Mm,
call a
yeah.
hepatologist or a gastroenterologist. Yeah.
So, brother, you see the problem with cirrhosis is it causes portal hypertension, and portal
Yeah.
hypertension causes a big spleen, and then all the platelets get secreted in the
So,
spleen.
so,
So,
yeah.
by managing the portal hypertension, you should be able to get control of the hypersplenism. So, how do you
Mm,
manage portal hypertension? Okay, you got to get rid of the SITs. You got to do acetic tap. You got to go do diuresis with Lasix and aldactone, right?
mm,
Sometimes you consider giving the patient albumin. You tell the patient
mm,
to stop drinking if drinking is precipitating it, right? If there's an upper GI bleed with esophageal varices, then you want to do a scope and you want to band those
mm,
varices, you know.
mm.
So your management of cirrhosis and portal hypertension will help you control the hypersplenism, and then the platelets also improve as well.
Awesome. Are there any indications for a bone marrow in any of these conditions? And maybe is it safe? Where will it be safe?
Yes. Okay, brother. So if we covered that one section where we said marrow hypoplasia, infiltration of the bone marrow. So if you
Mm,
investigated the other stuff and nothing is coming up, and you've done
mm,
serology for malaria, you've done serology for your viruses, and nothing is coming up, and you thinking
mm,
there's something infiltrating the marrow, maybe there's a leukemia, maybe there's a lymphoma,
mm,
then you discuss with hematology and you marrow the patient. Platelet counts above 50 is
mm.
safe for a marrow. I mean, I even marrow patients with platelet counts of around 20. But below 20, I get very nervous. But above 20, I think it's okay. Yeah.
Mm. Yeah, someone was saying I must lower the CCP. Oh, I don't know how to do that. Okay, it's thanks for that. I think it's important feedback. Where did I see it? Oh yeah, Kamuhelo. Says they can't see the on my iPad is fine. Brother, and on your screen, do you see the clinical care platform logo?
So now the comment you have is just above the logo. But I think when you have more text in there, then
Yeah,
the
or
space becomes, and then the logo obstructs.
yeah, I need to get rid of. Okay, I'll find a way because usually the questions are supposed to be here,
See,
and
like now
yeah.
you moved the bar downwards, and now it's
So this is
obstructed
what you
because you moved
see.
it down. Yeah.
Okay, I need to figure out how to remove the clinical. Okay, yeah. Thanks for that feedback, colleagues. I think for those who are streaming online, they are not seeing that logo. It's the Zoom. So I will make a test and see how I will. Thank you, thank you, thank you, thank you. What time is it? Okay, let's take one more.
Mhm.
What's the difference between clamping and not clamping? Oh, I mean, like, I think,
Oh,
yeah.
no, excellent. I forgot to tell you guys. So
Yeah.
clumping, why do you get clumping? Because in the purple top tube, you got this reagent called EDTA, ethylene diamine tetraacetic acid. And so
Mm,
one of the weird things that it does is it has this reaction with certain kinds of platelets and it causes them to
mm,
stick together. So there, the
mm,
problem is not with the patient's blood, the problem is with the reagent.
mm,
So therefore, we do a smear. If it shows you clumping, you know that that's not the true platelet count. And if you're still not sure, you can do a FPC in a blue top tube. You know the INR
mm.
tube? You can tell the lab, listen, run a FPC for me in the blue top tube. That one doesn't have the reagent. So that will give you a true uh, platelet count. Yeah.
Last, so colleagues, this will be the last one. Sibuti, I'm seeing your HIV question. Yes, there's a relationship between HIV and everything in the world. So there is. There's questions about malaria. Okay, let's take this one and the malaria question, and then Jean, because we have answered one of your questions, I'm sorry. So we'll take this question and then the malaria question, and then we call it. So Nima says, how long does it take for TTP patient to present? Patients born with the Adam gene issues, do you need a trigger to be diagnosed? Because you said they're generally well. I think that is the
Hmm.
context of the question. Yeah.
Hmm.
Thanks,
Hmm.
brother. Then we'll
So,
take one
so
more question for the night.
thanks, bro. So yeah, so with Adam TS13, some patients are born, it's never completely absent. It is slightly deficient. But when you have an infection as a trigger, that causes worsening of the deficiency, right? So these patients often get sick only when they have a preceding like infection. Usually it's a diarrheal illness, right?
Mm.
And that pushes them down. So you hardly see this manifesting like on its own. Usually it's associated with a trigger. Yeah.
Awesome, awesome. I lost that question. Let me find
Malaria,
it. Did
malaria.
you? It's on there. Okay, there. Yeah. Okay, this is the malaria question. Sorry about that. Do you see many cases of malaria, black water fever in South Africa in patients without a history of travel to a malaria zone?
Yeah. Okay, we see malaria, right? Black water fever only if there's absolutely severe hemolysis, right?
Mm,
So in a
mm,
patient who's been sitting with malaria at home, I've been sitting and sitting there for days and days and days, been hemolyzing all the time, not coming to hospital. They're coming
mm,
profoundly anemic, they're coming with cerebral malaria, they have black water fever. But often
mm.
patients feel sick, and when they feel sick, they come in early and we catch them before they have the black water. But we do see
Okay.
a lot of cases, and some parts of KZN are endemic for malaria. So you may not
Mm.
necessarily have the travel history. It's just that they weren't taking prophylaxis, you know, and they come in sick.
Awesome, awesome, awesome. Brother Ryan, your closing remarks, your bye-bye sentence.
Nothing much, brother. Just thank you to everybody for attending. Thank you, Brother Mawela, for the wonderful opportunity. God bless you, and I hope to see
Always.
you guys soon with the next master, the Chest X-ray masterclass
Chest
on the 20th.
X-ray, chest X-ray. It's knocking on the door, colleagues. Is it the 23rd? Let me just see. Yes, Saturday. Am I in September? Saturday,
20th,
the 20. Where am I getting?
20th,
The
brother.
20th.
Yeah,
20th.
yeah.
20th. Chest X-ray masterclass. Just get ready. Include us in your budget there. We are ready to trade.
Yes.
Thanks, Brother Ryan. Colleagues, thank you so much
Thank
for
you.
making tonight's educational session to be a success. I've shared a number of links in the chat, the WhatsApp group where you can join so that you don't miss any of our events. And also, if you would like to join the membership program, if you are a nurse and you want to update your NEMAT certification, we have it this coming weekend. On that note, may I wish you a restful time with your families till we meet again next week. Bye. Bye bye,
Bye.
brother.
Bye,
I'd
bro.
like to.
Missed our latest webinar? No worries. We know life gets busy.